as we go. So we're going to talk a little bit about rotator cuff and shoulder pain today. So if you're looking for the Rotary Cuff Workshop, then you're in the wrong place. It's a little therapy joke we have often with therapy. We get a lot of people telling us they hurt their rotary cuff. This is for rotator cuff, not rotary cuff. We're going to talk about some shoulder pain and some rotator cuff problems and go through a few things here. So I can hear some feedback coming from somebody. Do you know if that's noise behind you, Noah?
It's not me, but if everyone else can just make sure that that they have theirs muted, that way there's not as much background noise. Well. Yeah.
And then when we get to like a question and answer part, we're fine to let you unmute yourself and talk. But for right now, I'll just put questions in the chat box so it's easier to deal with. So my name is Dr. Steve Bjorn. I'm a doctor of physical therapy and a certified strength conditioning specialist, a co-founder of Core Rehabilitation with my business partner, Noah Burton, who's also online here with us. And so like I was saying before, if you guys go ahead and maybe put in your first name and maybe something about what's going on with your shoulder, maybe give us a pain level, 10 out of 10 pain, it's time to go to the hospital. 0 is no pain at all, so give us some indication of what's going on with you. So put that in the chat and Noah can address those while I'm talking and can answer some questions. We'll answer more questions at the end. So feel free to jot those down and Noah keep track of those and we'll go over some of those at the end. So
yep.
As we're talking today, we're going to start off with kind of talking about what is the rotator cuff. So the rotator cuff is a group of 4 muscles, and those 4 muscles attach your shoulder blade to your humerus, or the long bone coming down your arm here. So they connect your body to your arm, and they make your shoulder move correctly. They sort of wrap around the head of the humerus. So the head of the humerus is like a ball, like my fist, and the rotator cuff wraps around that. And they help to stabilize that ball into the socket, and they also help to move that and raise that arm up as you move. So they're very important because the ball. I don't know if you can see. No, can you see when I move my cursor?
Yep, I can see your cursor. Yep.
Okay, so that ball part right there is the head of the humerus, and this little tiny space right here is the glenoid fossa. That's the area where the humerus articulates or moves around on the shoulder blade. And so that's a big ball on a little socket. To kind of compare it to a golf ball sitting on a golf tee. And so it's inherently a very unstable joint. It's a very mobile joint. We have a ton of mobility in the shoulders. We can do all these things with it, to throwing overhead, to reaching behind our back. So it's great that we have that mobility, but with all that mobility comes that instability a little bit. And so the rotator cuff is very important to help stabilize the socket and help that humerus move correctly. And we need to have not just that ball on socket there moving well, but we need to have everything around it moving well. So that includes the neck, the thoracic spine. So it says neck on the slide there, but it's the whole thing, the spine from the neck all the way through the thoracic spine. Let me just make sure I got a little notification of something about more participants. I want to make sure I wasn't not letting somebody in. I don't see an option to let more people in, so I think we're okay. So we have to have all that moving very well in order for the shoulder to do its job. If the neck, the thoracic spine, your collarbone, the clavicle here is not doing their job correctly, and the shoulder blade not doing its job correctly, and even the rib cage, your rib up on top right here, your first rib can affect the way your shoulder and neck move, as well as your ribs down lower can affect that. So if everything's not working correctly, then you're going to have more trouble at that ball and socket joint. That in the actual shoulder joint itself only accounts for 2/3 of that total shoulder motion. So if I only move the ball and socket joint, I can only get to about there, about 120 degrees. But when I get the neck, the thoracic spine, the collarbone, the shoulder blade, the rib cage, everything else to move the way it's supposed to, then I can get up to 180 degrees and get that full 100% normal motion. So if all of those areas aren't working correctly, then we're going to have a whole lot more trouble with the shoulder blade, with the shoulder itself. So, the slide about how we came to specialize in shoulder pain. Like it says on here, we have many, many years of experience in orthopedic physical therapy, and don't really want to admit how many years of experience we have sometimes, gives us a little age. You can see from the initial picture that was on that first slide that I've got a little more gray going on since the first slide when we opened up. And we've done extensive continuing education. Really, there's only about 5% or less of the physical therapists out there that have the kind of continuing education that we have in things from trigger point needling to myofascial decompression to total motion release to mobilization with movement, and all these hands-on techniques that we do that's different than what a lot of places are able to do for shoulder issues. And like I said before, we're certified strength conditioning specialists, so there's a lot of corrective exercise that we do that actually helps change the way that the shoulder is functioning and all those areas around the shoulder are functioning. And then we're connected with local orthopedic groups. We've had several people come by to actually learn from us. We have actually from Texas Women University, University of North Texas, Texas Tech University. We regularly have at least a few interns every year that they'll send to us to learn some of these manual and corrective exercises techniques that we do. So lots of time and experience working on that. And then myself personally, kind of my own story a little bit. I actually tore the labrum in my shoulder. So the labrum is a cartilage. So if you've got the glenoid fossa, that socket part of the ball and socket that we were talking about, around that bone, on the glenoid fossa, there's cartilage that goes all the way around that and comes out to try to create a little more stability and control in the shoulder. And I tore almost circumferentially, almost the full way around that labrum away from the socket when I was 16 years old in high school. And from learning how to do more shoulder blade control, changing posture, building up the rotator cuff and the muscles around the shoulder joint, I was able to continue to play sports and do things, lift weights and work and do everything I needed to do. And eventually over time, because of the instability that was created by that labral tear, it kind of got a little bit worse, and got to the point where I couldn't control that completely. I was going to have to either give up playing basketball or have surgery. And I knew if I quit playing basketball, I was going to get fat and lazy. And so I decided to have surgery at that time, but that wasn't until I was 30. So for 14 years, I had a pretty significant labral tear in there that didn't bother me regularly because I took good care of it with the type of stuff that we can show you if you were to come in here.
But Jamie's on the call. Jamie's on the call, Dr. Bjorn, and she mentioned in the chat that her husband has a torn labrum as well. So that kind of fits the story that he's dealing with right now as well.
Yeah. So depending on the severity of it, depending on the location of it, depending on what you want to be able to do, if you have a really big labral tear in your dominant arm in your, say, a baseball pitcher, there's potential that maybe you would need to have surgery to get back to that full amount because that's so much torque on the shoulder to be able to throw. But if your goal is just to be able to raise your arm and do some ordinary day-to-day activities, maybe lift a little bit of weights, pick up things, carry things around, then the vast majority of the time we can get enough stability of the muscles around the shoulder, the rotator cuff, the shoulder blade, that we can get by either without or put off for a very long time having to have that kind of a surgery. Not saying that every case, there's a lot of cases where things do need to be surgically repaired, but there's tons and tons of cases where it doesn't necessarily need to be repaired, and it doesn't necessarily need to be repaired right now as well. So that's a little bit about us. And I feel like I skipped quite a bit there. Okay. So here's the thing that will help you know if therapy is going to be effective for you. So about 90 to 95% of people can make a huge improvement with good quality hands-on therapy that retrains the muscles to help them work better. And way that you can know if it's going to make a difference for you or not is your pain reproducible? So in other words, is there an activity that you do, raising your arm up, reaching behind your back, reaching into the back seat of the car, laying on that side when you try to sleep at night? Is there something you can do, like some of these options down here, carrying something, lifting something, or reaching behind your back, getting dressed? A lot of people, when they pull their shirt off or try to reach back to unfasten a bra, get a lot of pain. If there's a thing that you do that produces your pain, so if that's the situation for you, then we know that your pain is also reducible. So if your pain's reproducible, then we can also reduce it because there's a mechanical problem going on. And the thing is that there's a lot of times where people will get an MRI and see, you know, well, this is, I've got a torn rotator cuff, I've got arthritis, I've got this, I've got that. And the fact of the matter is that the majority of those things were there long before they ever started having pain. They've done several studies in the last few years that have looked at MRIs of healthy individuals that have no pain whatsoever in their shoulder. And they found that if you're over 40, 80% of people have significant rotator cuff tears, arthritis, bone spurs, degeneration. So it's actually normal to have those things. If you don't have rotator cuff tear, arthritis, degeneration, bone spurs, and you're over 40, you're actually abnormal. So it's very common. If they're able to actually do an MRI when you didn't have pain, and then do an MRI after you had pain, in most cases, it probably wouldn't look significantly different. So we have those underlying problems. It's like gray hair and wrinkles. As we age, we all get it. Those underlying problems are there, but it's not until we do something that creates inflammation and puts stress on that. Maybe we lose a little bit of range in our thoracic spine. Maybe we lose a little bit of motion in our rib cage. And then all of a sudden, now when we go to raise our arm, it creates more pressure and pinching in that shoulder, and that rotator cuff fraying or tearing that's been going on for years now becomes very, very painful. And so it's trying to do a movement analysis and check that and see what's not moving correctly, and then we'll be able to get the pressure off of that. So we're going to talk a little bit about what we do to handle pain. So go ahead.
Well, I was just going to say, Barbara just asked the question in the chat, and you kind of were talking about that, but I think you'll cover that a little more here in a minute. She says, I have significant arthritis in my spine, especially in the cervical area. Could that be the cause of my shoulder pain? So I think that's kind of what you're touching on, and I think here in a minute you're talking more about that, but I just want to let you know that she was asking that question specifically as well.
Yeah, it's a great question. So I'm going to get into a little bit more detail about the neck and the collarbone, the shoulder blade, and all that kind of stuff here in just a second, and we'll talk about that for sure. So when we have something go wrong, we can ignore it. You know, these things sound like excuses, like, well, my dad had bad shoulders, it's inherited, or, you know, I did a lot of throwing when I was a kid and it's just worn out, or whatever. Those are, you know, excuses, things that we just kind of throw out there and try to pretend like it doesn't exist, or it'll just go away by itself. And I kind of use the analogy a lot of times when I'm talking to people about that situation of, if your engine light comes on in your car, what do you do? I mean, if you ignore that, then something worse is usually going to happen. It's usually going to be a better fix, a quicker fix, and a cheaper fix to address it right away. But if we just ignore it and pretend it's not there, the vast majority of the time, things just get worse. They usually don't correct themselves by themselves. They need some extra expertise to help correct that. We can alter it, which altering it looks like trying to just cover it up, like injections or pain medications that just try to numb the pain or try to decrease the inflammation. Don't really change the mechanics, don't really change how the shoulder is functioning, but they altered it. And so that might be like disconnecting the light to the check engine, or disconnecting the fuse to the check engine light, or putting some black tape or something over that check engine light. We don't see it anymore, and so we think it's okay, but we didn't fix the problem, we just covered it up. And then actually handling it is, you know, getting in there, getting it to the mechanic, trying to figure out what's actually wrong, why is this light coming on, and what can we do to address it now so it doesn't get worse in the future. And then now we're going to go into those kind of a little more detail on those most common causes of the shoulder pain there. So first one is the neck, like you were talking about. So with the neck, that's exactly what you asked of, you know, can arthritis in my neck be causing my shoulder pain? And the answer is 100% for sure it can be. Now, it's not guaranteed that it is, but it for sure can be. So and picture the nerves coming out of your neck is kind of like your garden hose. If you're watering your lawn or watering your flower plant and the water stops or slows down dramatically, what's the first thing you do? You're going to go look for a kink in the hose, and that kink is decreasing the flow of the water coming out to you. So, and when you unkink that hose, then all the water comes back out normally again. And that can be the case with the neck. If you have bad arthritis, if you've got a disc bulge, if you've got a lot of inflammation in the neck, joints in your neck that are kind of stuck and not moving well, that can actually create a little pressure on the nerve that's coming out of your neck, and you can get pain into your shoulder, and you can get pain all the way down to your hand. A lot of times we've had several patients that have either been misdiagnosed with a shoulder problem and it's coming from their neck, or a neck problem and it's coming from the shoulder. The two are so interconnected and so interrelated that it's very common that you'll get pain into your shoulder or all the way down to your hand, and that's coming from your neck. So, you know, checking the mobility in the neck, if say your right side is your bad side and you can't raise that as well as you can the left side, if you check your neck and turn your neck to the left and you turn your neck to the right, and if there's a difference there, if say the right side is the bad side of my shoulder and I turn my neck to the left, to the right, and it doesn't move as well as it does to the left, then there's a very good chance that some of that issue, maybe not 100%, but some of it is coming from the neck. And until the neck is addressed, then the shoulder won't be 100% because there's some restriction happening here. And that's not the only test we do. We do other tests to check and rule out things coming from the neck, but that's a simple one you can do on your own at home. If it doesn't move anywhere near as good to this side as it does to that side, then there's a good chance that that's coming from your neck. If that pain down your arm travels below your elbow, if it goes all the way down to your hand or fingers, there's a good chance it's coming from your neck. Not 100%, but there's a good chance coming from the neck. If it's more of like a tingling or numbness, burning or shooting, then that's a good chance it's coming from the neck too. That can come from rotator cuff issues as well. That's still possible. So you can't know for sure until you get it checked and do a movement analysis of everything. But yes, 100% for sure, arthritis in the neck can cause shoulder pain, definitely. So if we can get the neck moving right, then things are going to go a lot better. So the next most common cause of shoulder pain is what we refer to as an impingement syndrome. So you can see a little diagram here, this gentleman with the pain in his shoulder. So the humerus, like I was talking about before, is like a little ball, and the socket is the glenoid fossa where it rolls on there. If things aren't rolling smoothly, if the shoulder blade doesn't move the way it needs to, if the rotator cuff doesn't do its job well, when you go to raise your arm, there's the acromion, this word right here, acromion, is actually part of your shoulder blade, and it actually is like a little bony shelf right above the head of the humerus. And if it doesn't move out of the way like it's supposed to when you raise your arm, it actually pinches. And when it pinches off of one of those rotator cuff muscles called your supraspinatus. You don't need to remember the name of those specific muscles. There's 4 of them. But that one there that comes right across the top of the humerus, right across the top of the shoulder, gets pinched very easily when things aren't working right. If the collarbone doesn't move the way it needs to, the shoulder blade doesn't move the way it needs to, rotator cuff is weak, you got trigger points in the rotator cuff, any of those types of things can cause it to not move correctly. And when you raise your arm, it pinches. So this looks a lot of times like I try to raise my arm up and right around there, about that 90 degrees, I get that sharp pain here and it radiates down to like where my deltoid attaches right here. So if you get a pinching pain here and it radiates down like that, when you do certain movements, reaching across your body, reaching up, reaching back, and you get this pain that pinches here and radiates down here, that's very likely an impingement syndrome. And that's a mechanical dysfunction, and if we don't take care of that mechanical dysfunction, it will grind down on that supraspinatus and eventually cause a rotator cuff tear. Because picture like if you had a rope going over a metal edge and you didn't do anything about that, and it just rubbed and rubbed and rubbed and rubbed and rubbed, that rope would start to fray. And in the beginning, that's not a big deal. It's still a good, strong rope. But if you let that go on for a long time, that fraying will eventually weaken that rope and cause more of a problem. Get another person admitted here that just joined us. Okay. So that impingement syndrome is another very common shoulder problem. A lot of times people actually even have what we call a painful arc. They'll raise their arm up, they get a lot of pain there, and as they go up higher, that head of the humerus actually drops down and stays. So in the beginning, right, about that 90 degrees, it pinches, and then when it drops down and clears, and it's actually less painful up here. So it's kind of, they have pain through the movement, but it's not quite as bad at the top. That's a common scenario. People will be confused, why is it not hurt up here when it does hurt right here? Like if your arm's straight out in front of you or straight out to the side, and you're trying to go up and down, that's much worse than if you're all the way up here. And that can be addressed with the movements that we do and the analysis of that as well. And then the next most common cause of shoulder pain is the postural issues. So we know that pecs are ignored a great deal, and muscle underneath your arm, in your armpit right here, called your subscapularis. That's one more of the rotator cuff muscles called your subscapularis. Those ones are ignored a whole bunch for people. And those can cause a lot of trouble because they round that shoulder forward more. And if you can, like, do a little experiment for me right now. Try to round your shoulders forward and kind of really slouch and have real bad posture there, and then try to raise your arm up. So that's literally as far as I can go. That may be about 120 or so. I'm just barely above shoulder height. And that's because that, like what I was talking about, the shoulder blade, the collarbone, the rib cage, the thoracic spine, all has to move out of the way and clear for that shoulder to go. Now, if I really exaggerate, really stick my chest out, drop my shoulders down and back, I'll try to raise your arm up again. And for me, I can go past 180 now that I'm up here in this position. So when we do that, it greatly increases the risk for that impingement, and it creates a big mechanical dysfunction in the shoulder itself and puts a lot more stress on those underlying arthritises and underlying rotator cuff tears that have been there probably for years. Now they're starting to really hurt because of the roundedness of the shoulders, the tight pecs, and the weak upper back. The muscles that control your shoulder blades and pull your shoulder blades down and back have to be real strong and create a good foundation for you to be able to move the shoulder correctly. So postural issues is something that we work on a lot with, trying to change the way we do things in our function in our daily life, and trying to loosen up and release those tight muscles and strengthen up and build endurance in those weak muscles. Whenever a muscle is in a shortened position for a long time, it gets very, very, very tight and restricted. And whenever a muscle is in a lengthened position, like those muscles in the back in the first picture over here, then it's going to get very, very weak. And so it takes a lot of work to get those shoulder blades to come back and down and to loosen up and release the tight pecs in the front.
Steve, another good example of that, and just that's easy for people to realize, is if everyone will take their right hand and just make a fist as tight as you can, and you can feel how it's really easy to make a good fist there.
That neutral position like that.
Yep. And so you feel what that feels like. That's when your shoulder's in a good posture position, like that picture on the right. Now, if you bend your wrist, like Steve's showing in the picture, bend it there where it's not in a good position, and now try to make a fist there, and just feel the difference. And that kind of gives you an idea how mechanically the shoulder just does not function well when it's not in a good position, like that picture on the left with the poor posture.
Yeah, it's a great example because I can make a really tight fist and really strong here. I'm getting a hard muscle contraction there. I can feel it squeeze real strong and hard there because my mechanical advantage of the way my muscles are positioned there. I go like this, I can't even I can close my hand, but I cannot make a tight fist. So you guys can try that for yourself. And if you try it for real, you'll be able to tell you can't make as tight of a fist here as you can here. And that's what Noah is talking about with the positioning of the shoulder blade, the rib cage, the thoracic spine. It's going to make everything work a lot better by getting it in the mechanically advantaged position. Thank you. So then, what does successful treatment look like? How do you actually recover if you have any of these things going on? And the first thing is hands-on physical therapy. We have to get in there and do some manual work to make that collarbone move better, to make that shoulder blade move better, to make that neck move better, to make that thoracic spine and the rib cage move better. Sometimes that first rib can pop up here. Sometimes we can get just a ton of tension in the upper traps. This muscle that connects the neck to the shoulder has a lot of tension. If we're sitting there on a computer all day, if we're driving a lot and we're just very tense and tight and stressed, there's a ton of tension in that muscle, and that's going to not allow the shoulder blade to drop down like it needs to, because the upper trap elevates your shoulder blade. If it's always tight, the shoulder blade is not going to drop down like it needs to have the arm move the way it's supposed to. So there's lots of different manual techniques, from trigger point needling to cupping to deep tissue release, the mobilization with movement. There's lots of different things that can help get in there and mechanically change the way your shoulder's moving so that we can get stress off of those rotator cuff tears, those tendinitises, bursitis, arthritis, and that relieves a lot of that. And then the next thing is corrective exercise. So not just doing stretching. A lot of times when people go to therapy that has failed them in the past, they just say, well, they gave me a list of stretches and I just did these stretches and that was pretty much it. And that's not real therapy. Stretching isn't the only thing. Sure, you do need to stretch. Like if you have those postural issues, you need to stretch that chest and open up that chest. But in the majority of cases, we need to really try to strengthen the correct muscles. And that might be for the postural issues more the shoulder blade stabilizers. It might be for the labral tear, a lot more the rotator cuff. And the rotator cuff does get stronger when you do these little rotation motions that a lot of people have seen or know about. But a lot of people don't realize that the rotator cuff works best as a group. It's really going to stabilize your shoulder when all four of them are contracting together. And so those are things like weight bearing on an unstable surface. There's a lot of different things that we can do that try to activate and kick in some manual resistance movements, activate and kick in all those rotator cuff muscles together as a group and kind of teach them to function the way that they're supposed to help stabilize the shoulder. And so it's really corrective exercises that address whatever mechanically disadvantage is going on with each individual person to optimize that function in their shoulder. Another thing that we're fortunate enough to have here that a lot of places don't have is a class 4 laser. That's not a cold laser. Cold laser only puts out about 1/30th of the power of a class 4 laser. Actually, they were started with actually veterinarians doing therapy on horses, like race horses, and they were doing the laser on them and getting great results and getting horses to be able to run and do everything again. And it was actually about 10 years ago that it got approved for doing on humans, and all the sports teams, all the NBA teams, all the MLB teams, all the football teams got that right away and started realizing that they were getting a lot faster recovery. The biophoto modulation, so bio is biology, your body, photo is the light, and the modulation is changing. So that focused, powerful laser penetrates deep into your body and actually changes on a cellular level the way your body heals, and actually promotes healing and speeds up that recovery significantly. So we kind of compare it to like the fast pass at Disneyland. You can wait 2 hours and get on the ride, or you can get the fast pass and get on in 2 minutes. And we're not saying the laser is going to fix you in 2 minutes, but it definitely speeds up the healing process significantly. So we need to make sure we're getting our hands on people, changing the way that their shoulder blade, collarbone, neck, rib cage, thoracic spine's moving. Then corrective exercises change, and a really good added bonus there is that laser that speeds up the healing time recovery much faster. So, and what do you do if you want to try to actually address what's going on with you individually? So you can come into the clinic right now. If you're, we've been open, we're cleaning everything like crazy. We're doing everything that we can to try to make people feel comfortable and keep in space. I have all of our tables at least 6 feet apart, and we haven't had anyone come in that's ever had any sort of symptoms, fever, any kind of cough, anything. And so it's very safe to come in, but if you have some hesitation there, we can do a little bit of some kind of checking you out online. We can do some virtual treatment as well. But if you click on that link, or I think Noah was going to post that link in the chat section as well.
I'll put it in there right now, Steve.
Yeah, so you can click on that or copy it and paste it into your address bar there, and that'll take you to a place where you can request an appointment. We can get you a call and get you scheduled, or you can call or text the number there that's listed on the screen, and we'll get you going right away and get you scheduled so you can come in and have a movement analysis done. Because when you think about those pictures we were talking about, like an MRI, that picture's taken with you still in one space. And so it doesn't really necessarily show what's going on, because people can have pain in their shoulder just sitting still, but it's usually much more painful when they try to do something. That picture doesn't show you what's happening while you're moving and what's going on when you do something. So you may be getting that impingement where it doesn't look like anything when your arm's sitting by your side and still. But if we had a picture of it when your arm was up here, we may be seeing that supraspinatus tendon or that bursa is being pinched in there. And we can change the way that's functioning. So, you know, the first step would be getting a movement analysis done, seeing what's going on with you individually. We don't have a list of exercises. Here's what you need to do, because it depends. Is there more going on with your neck? Is there more going on with your shoulder blades? Is there more going on with your posture? Is there more going on with weakness in the rotator cuff? Is there more going on with tightness in your pec? We got to address each individual thing, what's happening with each individual person. So that's what you can do to try to address something right now. And then there's that link again, and you can get online and set up an appointment where we can also get you a call. You just give us a call, and we can, there's the phone number on the bottom of the screen there. We can get you taken care of. So is there some questions, Noah, that were in the chat that we didn't address with our conversation? I guess not a conversation, me rambling.
Yep, no, that's good. So earlier on, Dan had asked the question, will cartilage repair itself?
So cartilage doesn't necessarily grow back on its own. Once you get a lot of cartilage tears or a lot of wear and tear on the cartilage, and it kind of thins out, it goes from a nice thicker cushion as we're younger, and it starts to thin out as we get older and older and older. It doesn't necessarily repair itself. It really can't do that. So there's no way to actually change the way that cartilage is in there. There's been several things that orthopedic surgeons have been trying. Some of them have had some success with different types of injections into the joint to try to improve the synovial fluid. Synovial fluid is the fluid in the joint that kind of lubricates the joint and feeds nutrients to the cartilage. And if that fluid is healthier, then that can help it. There's different types of surgical procedures they've done to try to grow cartilage. And there's also, you know, the end thing that they do when cartilage is too bad is the joint replacements. So it's not going to actually rebuild the cartilage. That really can't be done yet. But what does happen is that it changes the mechanics around there, so it takes stress off of that worn out cartilage or that torn cartilage. So the goal with therapy when you have really bad cartilage isn't to really repair the cartilage. There's really nothing that can be done to repair the cartilage, but is to get the stress off the cartilage so that you don't have that. Like I was saying in the beginning of the conversation, you know, if you're over 40, you have arthritis, you have some wear and tear, and there that cartilage is starting to thin out and flatten out. And so it's going to be there. It's normal aging process, but if we can get everything around it to work normal, work better, get the muscles functioning better, get the rib cage to move the way it needs to, get the shoulder blade and the collarbone to move the way they need to, then you can decrease the stress to that significantly. So if you're 65, you know, and you have really bad shoulder cartilage and you have real bad arthritis, the goal is not to make it like it was when you were 20. The goal is to get the pain gone to where you can do daily functioning activities without pain. And that's very, very possible. It's really not possible to make it like it was when you were 20, but it is very, very possible to make it to where you can function really well without pain. We've had countless patients that have come in with pretty bad arthritis and left with no pain and normal motion. You know, if they go start throwing 100 miles an hour and lifting heavy weights overhead, doing handstand push-ups, pain's probably going to come back. But we can make a huge difference in the function and the pain level, even though the cartilage doesn't change, because remember that in 100 healthy people that have zero pain, if you're over 40, 80% of those, if you're over 50, 90% of those, if you're over 60, 99% of them have significant arthritis.
So Steve, Dan just asked, how about swimming? He was the one that was asking about the cartilage. He also asked about, how about swimming for the shoulder?
So exercises in the water is very, very good for arthritis, very good. But you normally want to start with things that are below shoulder height. Like, let's see if I can get to an angle where you can see my shoulders a little bit better. Like trying to do like in and out at shoulder height with your arms under the water, trying to do up and down to the surface of the water, trying to work on rotation and moving the arms in the water at below shoulder height is very good and can be done almost right away for most people to start building up the strength of the muscles around there and start getting the shoulder moving without as much pain. Actual swimming strokes, like a freestyle stroke going overhead, that frequently needs to be treated before you can do that, because your arms coming out of the water, it requires a lot of rotation of the body and full overhead motion and then coming back through again. So that motion is an end range motion that a lot of times you're not going to have that good motion and that ability to do that freestyle stroke until you get everything around the shoulder working properly. So like a freestyle stroke in swimming can be more aggravating to shoulder arthritis than it is helpful. But if you walk through the water and use your arms to push, if you exercise your arms under the water below shoulder height, that is actually very, very helpful. But you probably won't be able to get that freestyle stroke until you get the whatever underlying dysfunction is going on moving better.
So Steve, there was another question earlier too that you kind of touched on, and Dan just said, so competitive butterfly may be out of the question.
Yeah, I didn't mention butterfly because a lot of people don't know all the different strokes there, but yeah, butterfly stroke is the same sort of thing. You're going into that impingement position where you're very likely to pinch those shoulders there. So I wouldn't try to jump into competitive butterfly stroke.
There was another question earlier from Jamie. She just had mentioned that she has a pinched nerve in both, or having issues in both shoulders. So I don't know if you wanted to touch more on that. I know you kind of talked earlier about the neck and pinched nerves, but
yeah. So frequently, if it's both shoulders, and especially if you've had a diagnosis of a pinched nerve, then it's going to be something that's going to be needed to address centrally more into the neck itself here. So some spinal decompression, some manipulation, mobilization, some deep tissue work, some trigger point needling on the neck, trying to build up the stability in the neck itself, doing neck stabilization exercises, trying to get the upper traps to work correctly. They're usually way too tense and need to be contract, relax, rather than just contract, contract. So if we can get that released, that usually makes a big difference. Another thing that frequently goes into both shoulders is the postural issues. So if shoulders are rolled forward and you're real tight in your chest and your pec muscles, it's real hard to get your shoulders to pull back, really open up your chest and extend that thoracic spine. That's going to cause a lot of trouble to both shoulders a lot of times. So if you've been diagnosed with a pinched nerve and you've got pain in both shoulders, then there's probably a lot more work that needs to be done through the spine, through the rib cage, and through the chest in that area than actually just some shoulder stretches. Doing some shoulder stretches or doing just some band work for the shoulder itself probably isn't going to get it really good. It may help. It's definitely worth trying if it's not painful to do it. But usually when you're dealing with a pinched nerve and you're dealing with that pain radiating to both shoulders, there needs to be some work done on the spine. The spinal decompression, the laser, the manual therapy to the spine and the chest are very important in those situations.
So nobody's asked Steve yet, but you might just chat just for a second about insurance coverage for physical therapy and things like that. I'm sure people are wondering, you know, what's the cost. So maybe just quick overview of like about insurances and all that good stuff.
Right. Yeah. So the vast majority of the time, we'll take your insurance and your insurance will cover the physical therapy treatment. Now, if you have a deductible that you haven't hit yet, then there may be out-of-pocket costs to you. Or if you have a copay, there may be out-of-pocket costs to you. If you call and give your insurance information to us, then we'll be able to check and find out. You can also call your insurance and find out what your copay is or whether you've hit your deductible. But it's usually just a copay or a percentage that people need to pay. Worst case scenario, if you don't have insurance or if you haven't hit a deductible and you have it all out-of-pocket costs, we cap it at $85 a treatment for people. That's the absolute worst case scenario, would be $85 a treatment. That's an hour of manual therapy and corrective exercise. So it's a much better deal than you'll find anywhere else, especially for better quality treatment. But the way the law is written in Texas is that we can do 2 weeks of therapy before you need to worry about having a prescription from your physician or anything. So when you come in, we'll do a movement analysis. We'll write up a plan of care. We'll send that over to your doctor. And if your doctor just signs off on that and sends it back, then we can treat you as long as it needs to be done, because 2 weeks you should see a difference, but you may not be at 100%. So we can get that covered, and that's always covered by insurance. Now, Medicare, we need to make sure that after that first visit that your doctor's on board with that, and that they say that we'll sign off on it, or they do sign off on it, because the federal payers, and then there's some insurances like the military insurance, like the TRICARE, TriWest, that have to have insurance authorization before we do anything. The vast majority of the time, if you have group insurance, Blue Cross, Cigna, Aetna, majority of the time, we can just get you in right away, and it's covered by your insurance, and you may have a percentage or a copay, and every one of them is different. So just give the front desk ladies your insurance information, they'll check your benefits, and then let you know what your cost would be for you.
If maybe Steve, if you want to unmute everyone, and just that way, if anybody else has any questions, that was the majority of the ones that were asked in the chat. But if you want to give everybody a chance, if anybody else has any questions, just to ask them that way. So it looks like everybody's unmuted now, right, Steve?
I'm trying to. Gives me the option to.
I am muted.
All right.
Okay. Yeah. So feel free if anybody else has questions.
I'm good. I think Steve and I've talked a little bit during the last couple of weeks, so I think I'm good.
Good.
Okay. All right. So if you don't have any questions, feel free to give us a call or click on that link to schedule something. Or if you do come up with a question, or if you want to just have a virtual chat, we also will do for people, in addition to what we've already talked about, is setting up a full-blown evaluation and doing a full movement analysis, a free screen for people. So if you're not sure if you know what's going on or what you want to do, you can also set up either a virtual or an in-person free screen where we spend 15 minutes one-on-one with you for free to just kind of check and see what's going on with you a little bit and see what we could do to help you out. So we can also do that as a step into actually taking care of the problem, so that we can address and sort of give you. Obviously, it wouldn't be able to fix everything in 15 minutes, but at least give you some idea of what we think is going on and what we could do to help you. So we can do a free screen for anybody that's not sure, if they know whether this would help them or not, and we can see if there's something we can do for you. So that's always available, either with the phone number or that link to set that up if you're not sure you want to do a full-blown treatment course as well. And then if you have other questions, you can email me or rehabpt@yahoo.com, and we can answer some of those questions for you.
I'm going to put that in the chat box right now, Steve, your email address.
Okay, perfect.
So I just sent that in the chat box, so everyone has that.
I appreciate you all coming on here. If nobody else has any other questions, then we'll go ahead and wrap it up and be done for today. But feel free to contact me if you have any questions in the future. Anything else before we sign off?
Nope, thank you.
Okay, you bet.
Thank you all for coming.
It was great.
Thank you. And take care. Have a good day.
Thanks. You too.